I would like to now welcome back Drs. Jeff Nieder-Adipi and Dr. Patrick O'Connor and Dr. Colby Duran for our closing speaker panel and audience question and answer session. So to begin the moderated discussion, I'm about to ask each one of you one question and then we will open it up. Jeff, as we take a systems approach, what are successful examples of two-way communications at the community or organizational levels? And what are innovative approaches to deep structure communications compared to surface level?
That's a lot of question built into to one statement, but let me try to unpack that a little bit. I think we would all agree that in a perfect world, when you have two people communicating with one another, that it's really important for exchange and feedback in that communication for maximum effectiveness. You get feedback non-verbally, you can respond to questions, right? And that's a sort of optimal two-way form of communication. Well, once you scale that up to organizational or community level, it's a bit more challenging, in part because that communication becomes mediated. You don't have direct sources of feedback with various audiences, and so it can be a real struggle. But, I think I'll go to a point that Colby made pretty directly, that we often sort of put the cart ahead of the horse a bit when it comes to communication. We start with communication strategy rather than sort of shared agreement about goals and sort of policies that would achieve those goals. And so if you want to develop effective communication between a diverse and inclusive set of stakeholders, you need to be diverse and inclusive in developing the policy and the goals from the first place. And if you start with, here's a policy we're going to impose on this other group, and now let's try to have a buy-in from various groups, you're not going to get it because they weren't part of developing those policies, figuring out where money will go, and in the example of taxes that Colby brought up earlier. So, I really do think it's about shared articulation of goals. It's about having a diverse and inclusive group of stakeholders at the table from the beginning, and that enables communication strategy to better reflect interests of lots of different groups and organizations.
Thank you so much. Patrick, how do you bring to the surface deep level issues using data? And can you speak to the tension between the push for the use of big data and considerations around using it? Now, do we have representing deep structures for these data in these systems?
Yeah, thank you. That's an important set of issues. I think that I just want to talk a little bit about the limitations of the data that we have. In the description I gave of a way that we try to facilitate shared decision-making between clinicians and patients in clinical environments, most of the decision support technology that's in place right now is restricted to the data that's included in an easily retrievable form in electronic medical records or other related data systems. There's very little in those systems that's directly from a patient. For example, a patient would report their smoking status. They might be asked questions about their depression status, but pretty much everything else that's in there is filtered either through the lab, the patient's content of the patient's blood samples, or the patient's height and weight, or the patient's physical findings on an exam. So it's important to really, from the data point of view, there's a huge obstacle in the clinical environment that the big data systems generally are largely devoid of patient-reported information. There's a lot of chatter and literature about patient-reported outcomes, and that's very, very important. But I'm talking about upstream from the outcomes, patient inputs. What are patients' values? What do they find that's important to them? Those things are not in most big data systems right now. And I'm not sure that you want to use AI methods to try to get there. I mean, the way to do that would be to buy data from a credit card company and see. You don't want to go down that road. That's like Big Brother. That's like bad news. So how do we get the patient-reported data in that's relevant and that can be treated as confidentially as possible within the healthcare system to be incorporated in the data sets. That's a big challenge. And then the next challenge is how do you communicate with patients? I have to tell you a little story that when I started medical school, I went and bought a textbook of medicine, big fat book, 3,000 pages. And I thought, well, I'll start to read it now that I'm a medical student. I couldn't read it. I couldn't read it because I didn't know the language. And it took me a year and a half of medical school to learn the language to read the book. So I've learned that language. And guess who else speaks it? Other doctors and some nurses and, nurse practitioners and PAs and all that. But patients, by and large, don't speak that language. So now I'm fluent in a language that my patients don't understand. And when I open my mouth and talk to my patients, I'm often using a language that's but a lot is lost in translation, one way or the other. So how do we address that communication problem? Doctors thinking quantitatively, what's the benefit to the patient? A, B, C, D. Patients are like, hey, I'm never going to stop smoking. This cigarette is my little buddy. Got me through tough times. That's the last thing I'm going to get rid of. And then the doctor's at a loss as to what else to talk about. How to get patient preferences in there. So those are some of the things that come to mind. I don't know any easy solutions. I would just say that's where some of the frontier is in healthcare research.
Thank you. Those are really spot on points. Colby, are there examples to consider how agricultural policies can be pursued that also positively and equitably affect climate change, health concerns such as antibiotic resistance, and other population health concerns? And what would policy change that addresses these multiple impacts look like? Sure, I'm sorry, I'm asking you all multiple questions. I'm taking moderators, the moderators exception.
No, thank you so much for that question, all these important questions. I can definitely speak to what it would look like, particularly within climate change, and I'll talk about some of the other health stuff and maybe some of the food impacts. I'm definitely not a doctor and don't speak to antibiotic resistance. But one of the things that I mentioned in the conversation that we had earlier was really, when we're looking at developing these large scale policies, so often we do so in their own buckets or silos and areas. I think climate change, from what we've seen so far, I think I have a particular concern that that's what we're doing again. So when these policies are created, it comes from an angle of, okay, how do we solve climate change at USDA? How do we solve climate change at the Department of the Interior? How do we solve climate change at EPA? And all of these things sort of exist not only in their own departmental buckets, but also in their own issue area buckets. So with this kind of moment that we're in, where there is, I would say, a very strong focus on climate change action and potential for action, both administratively and certainly congressionally in agriculture, a lot of the proposals that have been put together, sometimes, like as we discussed before, just don't have that sort of inclusion, I think, of all the stakeholders and folks available at the table to have those conversations. I would say a very strong example of that is one of the first hearings that was held on climate change at Senate Agriculture Committee didn't have any producers of color at the table to talk about what the solutions might be for their communities as well. And so those voices aren't included. So we don't know if things like carbon banking or other components, what those impacts will particularly be in that. So it's tough to be able to weigh in them as that's where it's going. If you look at some of the things where they're wanting to have inclusion, it's like, creating a committee, but then it's saying, oh, there will be a representative from socially disadvantaged producers, which is sort of USDA's term for BIPOC producers. But is that going to be representative and supportive of the changes that need to happen? And then the other part of that is really, not only in the representation component of it, but are we going to miss this moment, and are we going to create a climate change initiative at USDA that will be its own thing and sit there, that when there's a change in administration, regardless of who it may be or what party they may be, they might want to have their own initiative. And is that work and effort just going to kind of go aside to something else coming in? Is it going to be not as important? In the tribal climate change context, we've actually seen this at the Department of the Interior. In 2014 or 15, they had a Bureau of Indian Affairs climate change funding pot, and it was just a little over $8 million. But it was something that was incredibly important and hard fought, got a lot of applicants every year, supplied money for tribes to be able to develop climate change action plans and programs. Then you have a new administration come in with different priorities and funding priorities, that goes away. And that can happen in any context. So when we look at making these larger scale changes, I know particularly with agriculture, we want to look at it throughout the entirety of all of the programs and the existing programs, because particularly USDA already deploys money on the ground that producers need to and producers have to be reactive and responsive to that and the requirements that go along with that. So why aren't we looking at the requirements to those programs, and how are we supporting and empowering producers that want to take a step towards regenerative agriculture to be able to help support the health of their lands and productions and what they're producing? If we're not looking at it in that case and saying, not only do we need to address climate change, but we need to address conservation programs and access and what can be done with that funding, and particularly access to credit and the credit programs at USDA, which deploy that money on the ground. And do you feel comfortable as a producer saying, I want to take a regenerative step, but then if I do that and I have a difficult year, or maybe my balance sheet isn't what my banker thinks it should be, then I'm going to have my loan called. So we have to look at all of these things together. And if we want to solve this, and I would say this goes to health concerns too, it has to be woven into the governmental fabric of the entirety of the departmental programs itself.
Thank you. Super spot on comments to get us started. I want to re-emphasize that I'm opening this session up for audience questions. I don't see any audience questions yet, but please type them into the chat box and include the speaker to whom you are directing the question if relevant. And note that due to the limited time, we may not be type away. All right, so until I see some audience questions, I'm gonna start to engage you in a little different way. So what if the data aren't available from each of your perspectives?
Well, I would just say in the clinical context, if the data aren't available, you talk to your patient, right? And that's how clinical encounters are structured anyway. And you try to find out what people's priorities are. So under the rubric of obesity management, you have to sort of explore some of the root causes of obesity. And then you have to sort of find out, is a patient interested in doing something about that or not? Now, if they are interested and there are communications problems with that patient related to culture, language, or whatever, it becomes very, very challenging to sort things out. For example, in Minnesota, where I am, we have many Somali and Hmong patients, and the concepts of diseases, certain diseases like diabetes or epilepsy that are prevalent in the culture historically are quite different than the Western biomedical model. So there's a lot of challenges in terms of communication and understanding what each other mean. But I think that those kinds of verbal transactions are the essence of healthcare. They are kind of individualized. I very much respect the policy and law intervention approach to obesity prevention. And as I mentioned before, prevention of obesity is priority 1, 2, 3, 4, 5. But when you do have a patient and there is a clinical issue, the communication around that issue becomes very, very important, very personal, and it goes way beyond the data that's in the systems already.
Are any of you aware? I'm sorry, Jeff, I'll let you talk in 1 second. But Patrick, are you aware of any Epic or other electronic health record platforms that would allow me as a physician or clinical care provider to actually input the patient's, besides just in the clinical care note, but an opportunity to actually put it into an area, maybe in the problem list or somewhere highlighted about the person's concept and construct of, their values, their beliefs, what are their preferences, how do we get these systems to change so that they are more person-centered and community-centered with respect to values, preferences, and that will obviously, like you say, help us drive better care.
Yeah, that's an important point. Most EMR systems, including Epic and Cerner and others, have something that they call a patient portal, where information can be exchanged back and forth with the patient. To date, mostly that's been used to display information that the patient can get into their portal and take a look at your lab results, or now the visit notes because of new laws and so forth. But the technology is being developed in many systems, including Health Partners in Minnesota and other places, where before the visit, the patient's given an opportunity to comment at some length about what's on their mind, what's important to them, and so forth. The deeper dive into what does, say, diabetes mean to a patient, there's some very good work by a guy named Arthur Kleinman called explanatory models of disease, a set of questions that you can ask a person who's recently been diagnosed, say, with diabetes, or if you want to talk to them about that, or obesity or some other issue. Well, who do you know who had it? What happened to them? What does it mean to you? What have you tried already? What do you believe will work? What do you believe won't work? Those kinds of questions are often woven into the clinical encounter. It's an interesting idea that you raised. Could we incorporate that kind of communication guide into clinical decision support? That's something I'll take home tonight and think about some more. That's an
Yeah, what I'd love to see, I'm going to put it out there to the audience and to you all, because you're experts, is, you know, how we always talk about the learning health system. I mean, the National Academy of Medicine, is big on learning health systems. But what about, that's at the systems level. Can there be a learning health system for the individual patient that would help the patient's preferences and constructs and their views and values drive the learning for that clinical care team for that?
Well, yeah, it certainly
There's
could.
a way to do it, but the deep learning for an individual patient. Yeah. Jeff and Colby, did you want to talk a little bit about, either of you, about the if data aren't available?
I guess I would just say, in my experience, the data are almost never fully available to a level at which we can be certain about what the outcome is going to be when it comes to systems level changes. And I guess I would raise the question of what data is relevant to the question is a pretty broad question as well, right? There's data on health impacts, there's data on economic impacts, there's data on social impacts, there's data on equity impacts. And so ultimately, I think we're never going to have a perfect picture of what's going to happen if we implement policy A in community B, right? What can we do in the absence of that? One, I think we can try to predict what those effects are going to be, and having, again, as Colby pointed out earlier, having a broad, diverse group of stakeholders at the table to identify some of those potential impacts based on lived experience is critical. And I think second is setting up every time we go to make a systems level change to have evaluation in place to learn each time we do this, and consider each implementation of a policy an opportunity to learn about a case, to make sure we ask the right questions about not just health but equity impacts, social economic impacts, and beyond. And then we'll be in a better position the next time we try one of these policies in a different community to learn from that previous experience.
Thank you for that. I really believe implementation science, when it's applied across different sectors, is super critical. I mean, it's kind of like it's got to be the bread and butter science moving forward for a lot of things, just like epidemiology was back in the day. I'm not saying epidemiology is not still important, but implementation science needs to rise up to that level as well, with being, this is what you learn as one of the common core courses within a public health or another graduate level degree. Wow, the questions are pouring in now. Ask and you shall receive. So are you aware of any public health infrastructure initiatives that can impact obesity prevalence in the United States that are included in the current U.S. Congress infrastructure bill? It could be for anybody.
I'm glad to go. I think So, we're not 100% sure where things are going to go or what it's going to look like. I think with some of the specific particular programs and things that are in there, I would say, I think particularly from our perspective, one of the most important things that you could do in an infrastructure bill to help support public health would be helping build out access to water, to homes, and being able to help support those types of components as well too, where you can have running water in places that don't have it, or have regular access to healthy, safe drinking water as part of it. I know that type of infrastructural component is something that's being talked about a lot as well. And I think another thing that may be marginally, tangential to this, but I think important, is also building out access to broadband. I think that is probably the lead that they're looking at outside of some of the physical built infrastructure, is broadband access, and particularly in rural areas, and also throughout Indian country. And what that would be able to hopefully do is not only provide that access to everybody, and to students, and to support, but also do so and provide opportunities for additional telemedicine, and also support the ability for additional health clinics and health facilities to be built in those areas that have access to records. So then you're supporting access to healthcare as part of that component, and making it easy for folks in rural areas without the support to have access to all of those.
Thank you. This one is directed to Jeff, but anyone can answer. Can you comment on the health communication messages that happened with COVID and obesity? What worked well and what didn't? And do you see any areas where there may be unintended consequences in widening disparity?
Yeah, well, certainly COVID, I think, revealed deeply seated inequities that have been present but are exacerbated by a crisis like that. There's all sorts of challenges that have come up communication-wise with COVID. I mean, I guess I'll speak to a couple. One, I think when you have a government sending mixed messages from its own institution about what is evidence-based, science-based practice, that's not only confusing to people in the short term, but I think it has very clearly undermined trust in public health institutions in this country that we're going to live with for a period. And it's a lot easier to unravel trust than it is to build it. And so, groups like the CDC, who have seen a dent in their trustworthiness over, politicization of process and messaging, I think those are going to take a long time to heal. I guess the second thing I would say is, and I think this is a broader problem, is that we communicate, and we often sort of advocate to communicate in clear, simple, definitive ways. And when you're talking about complex emerging science, when you're talking about complex systems, you can't boil that down to a 140-character soundbite in a way that I think doesn't have the risk of long-term consequences. So let me give the example of the mask advice early on in the pandemic. Very declarative: don't get masks. Masks don't get help. Don't buy them. Well, that message was wrong. It wasn't incorrect in the short term in the sense that medical care frontline workers there was a shortage and needed N95. But, people want definitive answers, and we give it to them when there's still an emerging science coming here. I think there's a real long-term risk. Science is not an answer. Science is a process, and we learn things over time. And I think we need to learn how to communicate about health issues in a way that recognizes when there's uncertainty, recognizes when this is the best we have now, but as we learn more, we need to update our recommendations. I think that gets us in a lot of trouble, and I think COVID's early days revealed a lot of that.
Thank you. I found really interesting, it wasn't only the masks don't help, but the second one, when the masks were to be used and do help, the concept of the mask was to help others and not yourself is incongruent with the United States more self-centered as opposed to outward centering of community. And so I find that really interesting. Do you have any comments on that? And I wonder if that relates to obesity as well.
Yeah, I mean, I think we often default in public health to protect yourself kind of messaging. So we're not very good at sort of collective messaging for the collective good. And I think that reflects one of those stumbles. I mean, in the case of a mask, it protects both you and community. But, look at our traditional messaging. It's sort of based in fear. And what kind of, when you have a fear emotion, you want to protect yourself. It's sort of an inward facing kind of emotion. And I think we need to learn how to do a better job of communicating about collective benefit, about thinking about other groups that are important to us, not just, family, but larger collectives. And I think there's a lot to learn about how to do that effectively in this country.
Jeff, can you hear me?
I can hear you now, yes.
Yeah. Do you have any advice for me and for the clinical world in terms of communication science? What would you say are some of the big things that clinicians could do when you're in a room with the patient, a diverse group of patients with the varying priorities and so on and so forth? Throw us a life raft. What should we be doing? What's your advice?
Well, I'll my expertise is not on doctor-patient communication, so I'll just caveat what I'll say with that. But I think listening, as much as talking, is an important part, and that's really hard to do when you're pressed for time and have a very limited window in which to communicate with a patient. I think your point earlier about speaking not in terms of sort of numerical risk, but other ways to convey not only risk and benefits of various treatments, but doing that qualitatively in a way that promotes understanding rather than 4% versus 2%. I think even pretty sophisticated patients who are dealing with high levels of stress, anxiety, and emotion aren't in a great place to process complex numerical information in the context of a clinical medical encounter. So those are a couple of things. And I think thinking about all of the other forms of communication beyond this sort of primary communication with the doctor, are there ways in that medical encounter through nurse practitioners, through other forms to offer patients more information, opportunities to ask questions and get responses in that setting?
Thanks.
Yeah, I think we're getting down to the end of our panel. We may have lost Melissa, but first, what I would like to do.
I got
you're
that,
back.
Yes,
Okay, good.
Angela.
So I was just gonna thank the panel because we have about 2 minutes left. So I'm gonna turn it back over to you, Melissa, and then maybe we'll have time for just one last brief question, and then we'll go to our closing.
Yeah, my internet is unstable, so I think you might have to.
Okay, so we have just a last question. The assertion of a false dichotomy between obesity care and policy to change food systems is problematic for people living with obesity. Can we not pursue both? And it would be great, again, we have 1 minute, but what do you all think about that? Can we not pursue both? Is it an either or?
Well, certainly not an either or. I think that it's important to pursue both. And the so-called obesogenic environment is the driver, and it has, we've talked for a few hours now about the root causes of that. Those need to be addressed, and that needs to be considered. And the lifestyle approach to prevention of obesity and management of obesity is got to be baked into the clinical side as well as on the political and legal side of the system. And sort of a united front is what's important. The basic stuff, the lifestyle stuff, the physical environment, social environment, those things are undermining and undercutting the effectiveness of medical treatments. You need to address the whole ball of wax, or we're not going to get anywhere very fast.